Navigating the ever-evolving landscape of medical guidelines can be challenging, but new recommendations for hypertension management offer fresh perspectives and crucial updates for clinicians and patients alike. These recent insights emphasize precision in diagnosis, broader screening for underlying causes, and tailored, often more aggressive treatment strategies, all while simplifying the approach for better patient outcomes. One of the most foundational lessons from these guidelines centers on the critical importance of accurate blood pressure measurement. Improper technique is identified as a leading cause of misdiagnosis and mismanagement. To ensure precision, home blood pressure monitoring is strongly encouraged, ideally twice in the morning and twice in the evening for 3 to 7 days. It's often suggested to discard the values from the first day and then average the remaining readings. Crucially, clinicians should take the time to validate a patient's home device in the clinic to ensure its accuracy. The guidelines also provide clear, actionable steps for patients taking their blood pressure at home. These include monitoring at the same time each day, with ideal times being after waking and urinating and before bedtime. Patients should sit quietly for 5 minutes without talking, with their back supported and feet flat on the floor, avoiding crossed legs. The arm should be placed at heart level, relaxed, and the cuff applied directly over bare skin, not clothing. Using an appropriately sized cuff is essential, as one that is too small can artificially elevate readings. Finally, patients should record 2 readings each time. It is vital to note that wrist-based and cuffless blood pressure devices are not yet deemed ready for clinical use, and only validated upper arm cuff devices should guide medical therapy. For example, data on the Apple Watch revealed a sensitivity of only 41% for detecting hypertension, meaning it would miss 59% of actual cases. Moving beyond measurement, the initial laboratory workup for all hypertensive patients has been expanded to include a urine albumin to creatinine ratio, or UACR. While standard initial tests still include a complete blood count, basic metabolic panel, lipid panel, hemoglobin A1C, thyroid stimulating hormone, urinalysis, and an electrocardiogram, the addition of UACR is significant. This is now recommended for all newly diagnosed hypertension patients, not just those with diabetes. The reasoning is that albuminuria can signal the earliest signs of organ damage from hypertension or indicate underlying primary kidney disease contributing to the high blood pressure. It can also point towards conditions like primary aldosteronism, given that aldosterone is directly toxic to the glomerulus. This brings us to a substantial shift in screening for primary aldosteronism, which is now recommended for anyone with stage 2 hypertension, defined as blood pressure greater than 140 over 90 millimeters of mercury. This greatly broadens the screening population, moving beyond the previous focus on only resistant hypertension. Even in the absence of hypokalemia, screening is advised. The recommended test is an ambulatory plasma renin to aldosterone concentration, which can be checked without stopping most antihypertensive medications, with the exception of mineralocorticoid receptor antagonists. An aldosterone to renin ratio of over 20 to 30, alongside a high aldosterone level greater than 10 to 15, strongly suggests primary aldosteronism and warrants further investigation. Notably, an elevated ratio, even while on an ACE inhibitor, ARB, or diuretic, is particularly suggestive, as these medications typically raise renin, which could otherwise lead to a false negative. It is important to remember that aldosterone levels can still be within normal ranges and suggest primary aldosteronism if renin is low. When it comes to treatment decisions, the guidelines offer nuanced approaches based on hypertension stage. For patients with stage 1 hypertension, typically 130 to 139 over 80 to 89 millimeters of mercury, pharmacological therapy should be initiated immediately if they have a high 10-year cardiovascular risk. The PREVENT calculator is recommended, with a risk threshold of greater than 7.5%. Patients with existing cardiovascular disease, chronic kidney disease, or diabetes are automatically considered high risk and should also start medication. For those with a lower risk, an intensive 3 to 6 month trial of lifestyle modifications is an acceptable initial strategy before considering pharmacotherapy if blood pressure remains elevated. Conversely, for stage 2 hypertension, or blood pressure greater than 140 over 90 millimeters of mercury, immediate initiation of therapy with 2 drugs is now recommended, preferably using a fixed-dose combination pill. This strategy aims to improve adherence, achieve faster blood pressure reductions, and ultimately improve patient outcomes.
The thinking is that waiting for lifestyle modifications alone or starting with monotherapy simply takes too long and is less likely to be effective. Preferred combinations often include an ACE inhibitor or ARB paired with a long-acting dihydropyridine calcium channel blocker, such as amlodipine, or a thiazide diuretic. It is also noted that due to its short half-life and variable metabolism, losartan is often a less ideal choice compared to longer-acting ARBs like telmisartan or valsartan. A significant conceptual shift in the guidelines involves the term hypertensive urgency, which is now considered obsolete. A blood pressure greater than 180 over 120 millimeters of mercury without evidence of acute end organ damage should be documented as asymptomatic severe hypertension, not an emergency. The key takeaway here is that this condition does not require acute intervention or rapid lowering, which can actually cause harm, including ischemic stroke, acute kidney injury, or myocardial ischemia. Instead, the appropriate management involves initiating or titrating a long-acting oral antihypertensive and arranging for outpatient follow-up. Interestingly, treatment goals for older adults have become more aggressive, targeting a systolic blood pressure of less than 130 millimeters of mercury. Drawing from trials like SPRINT and STEP, this target is now recommended for nearly all adults, including those over 65, provided they can tolerate it.
The primary exceptions are frail patients with multiple comorbidities or limited life expectancy, where goals should be individualized and deprescribing might even be preferred. Asymptomatic orthostatic hypotension is not necessarily a contraindication to intensive blood pressure lowering, as it does not appear to increase the risk of falls. Similarly, a wide pulse pressure, for example 170 over 60, should not preclude medication, as cardiovascular benefits are driven by systolic reduction and have been shown safe in clinical trials. Another pivotal change is the elimination of race-based treatment recommendations. Previous guidelines suggested preferentially using thiazide diuretics or calcium channel blockers as initial monotherapy in Black patients. This recommendation has been removed. The rationale is that the supporting evidence came from older trials focusing on monotherapy, whereas the modern approach emphasizes a race-agnostic strategy that prioritizes rapidly achieving target blood pressure with effective combination therapy. This change also simplifies the treatment algorithm for all patients. Finally, the guidelines place increased emphasis on lifestyle modifications, specifically regarding dietary potassium and alcohol consumption. While sodium restriction rightly receives much attention, there is a strong recommendation to increase dietary potassium intake, which has an independent blood pressure lowering effect. Potassium-rich foods include tomatoes, potatoes, and avocados, and potassium-based salt substitutes are also recommended, as they can significantly reduce stroke and major cardiovascular events. However, clinical judgment should be exercised in patients with moderate to severe chronic kidney disease, baseline hyperkalemia, or those using potassium-sparing diuretics. Regarding alcohol, the modern understanding suggests that any level of consumption can raise blood pressure, leading to a new recommendation for complete abstinence. In summary, these fresh hypertension guidelines represent a comprehensive update, urging clinicians to refine blood pressure measurement techniques, broaden screening for underlying conditions like primary aldosteronism, and implement more tailored, often intensified treatment plans. They underscore the importance of early dual drug therapy for stage 2 hypertension, redefine the approach to asymptomatic severe hypertension, set more aggressive targets for older adults, and eliminate race-based treatment algorithms. Additionally, the guidelines reinforce lifestyle interventions with a new focus on increased dietary potassium and complete alcohol cessation, ultimately aiming for more effective, personalized, and streamlined hypertension management.